All right, welcome everyone to our second meeting of the RFS Journal Club webinar series. My name is Justin.
Hello.
Hi, and I'm Amir.
And we are the RFS Journal Club coordinators. So for this session, we're happy to have Monica Uceda, a resident from the President St. Francis Hospital in Illinois, present to us about topic about Neointimal hyperplasia.
Yes, and thank you for that introduction, Justin. And we're really excited for the talk tonight by Monica. As always, we're inviting members from all service lines to participate and contribute to our Journal Club series. If there's any topics you or your service line would like to present, please email either Justin at justin-guan@uiowa.edu or myself at arashid3@uic.edu, and we will add you to the presentation schedule. All presentations will be broadcasted live to the entire RFS community, and like all webinar meetings, each session will be recorded and uploaded to YouTube afterwards.
And thanks, Barbara. And throughout the presentation, if you have any questions or comments, please type them into our questions box or hold them until the dedicated discussion time, and we will address those. So without further ado, let's welcome our presenter, Dr. Monica Uceda. And let me change presenter to...
Thank you, Justin. Thank you, Amir. Welcome, everyone, to the Summer Journal Club. My name is Monica, as he said. I'm Monica Uceda. Hold on, let me just switch my screen. Perfect. Okay, can everybody see the screen?
Yes.
Okay, excellent. So I'm an R3 at present St. Francis Hospital in Evanston, Illinois, and I'm the current chair of the RFS Women in IR committee. I also like to thank Akil and Mithil, the Vascular Disease Service Line, for their support in the preparation of this webinar. I think we have some background noise. We can mute all of our... I think we're good now. If you can't hear me, let me know, but I think we're all good. Today, we will take a deep dive into the endovascular management of chronic limb ischemia, specifically femoropopliteal disease. We will start with an overview of the subject, which will help us to understand basic concepts. Then we will discuss 3 landmark papers in drug-coated balloons and drug-eluting stents. These devices have substantially changed the endovascular approach in the last few years. After a few minutes for questions from the audience, get ready for the fun. The fun begins. Get your mobile devices ready for this interactive session. We will review 3 clinical cases, and you will be able to participate in real time for a more dynamic learning experience. It is my pleasure also to introduce our faculty mentor this evening, Dr. Vatakencherry, whom many of us know as Dr. V. He's the program director of the Diagnostic Radiology Residency at Kaiser, Permanente in LA, and an outstanding interventional radiologist. His knowledge and experience of vascular disease will bring important insight to our discussion. Not sure if he's logged in yet, but if he is there, if not, he's going to join us very soon. And thank you, Dr. V, for helping us tonight. Without further ado, let's start our journal club. Let's see. Perfect. In the U.S., 5 to 12 million people have peripheral arterial disease. The prevalence is approximately 4.3% in individuals older than 40 years old and 14.5% in those older than 70 years old. We can see the prevalence of peripheral arterial disease is directly related to age. Peripheral disease can be asymptomatic, and it is described that for every patient with symptomatic PAD, there are other 3 to 4 subjects with peripheral arterial disease who do not meet clinical criteria for intermittent claudication. So that it's very worrisome, and it becomes even more worrisome when the statistics demonstrate 10 to 50% of patients with intermittent claudication have never consulted a doctor about their symptoms. And all these stats are taken from the TAST, and the TAST paper, we'll talk about it later, but it's important that we all know that. There are some risk factors contributing to peripheral arterial disease, and specifically those that I mentioned here: race, gender, smoking, diabetes, hypertension, dyslipidemia. It increases the risk by a lot. The race is 2 times, and smoking, I think, has a stronger relationship to peripheral arterial disease than it does with coronary arterial disease. So we have to keep in mind those things. So next slide is a bit crowded, but the purpose of it is to show how detrimental this disease can be if not managed adequately and in a timely fashion. I want to point out that the progression of peripheral arterial disease is identical whether or not the subject has symptoms in the leg. We have to keep in mind this is highly dependent on the patient's level of activity. It's not going to be the same for a sedentary person or a person that walks a lot. So we have to keep in mind the kind of patient we're looking at, and we also have to be clinicians and not only like traditionally called plumbers. We also now, especially with IR residency, we have to keep in mind that we need to see the patient as a whole and take some ownership of the patient. In the case of critical limb ischemia, studies demonstrate approximately 40% of patients will lose their leg within 6 months, and up to 20% will die. So mortality and amputation percentages are high. This is the reason why management is so important and why we are discussing this tonight. Here are some definitions that we'll keep in mind throughout the talk. Intermittent claudication, it's defined as muscle discomfort in the lower limb reproducibly produced by exercise and relieved by rest within 10 minutes. Chronic limb ischemia, patients with typical chronic ischemic rest pain or patient with ischemic skin lesions, either ulcers or gangrene, and the presence of the symptoms has to be longer than 2 weeks. Acute limb ischemia, sudden decrease in limb perfusion causing a potential threat to limb viability within 2 weeks of the acute event. So the cutoff there is 2 weeks. You have to keep that in mind. So there are 2 well-known ways to classify peripheral arterial disease. The most commonly used is the Rutherford classification. In the prior slide, we defined critical limb ischemia as a patient with rest pain, ulcer, and gangrene, right? This corresponds to Rutherford class 4, 5, and 6. So these are the patients that have the most severe symptoms. And claudication is from 1 to 3. This is a very important clinical classification, so we have to keep this in mind when we see our patients and then correlate this clinical classification with the angiographic results in order to have a more complete and multidisciplinary approach to these patients. Now, we're moving on to the workup. What's included in the workup for a patient with peripheral arterial disease? So vascular lab will perform non-invasive physiologic studies such as ankle brachial index. This confirms the diagnosis. Less than 0.9 corresponds to claudication, and less than 0.4 will correspond to rest pain. You can also do exercise, ABIs, and the changes more than 0.15 or more than 0.1 with symptoms are significant. You also have pulse volume recording, you have toe pressures, and you can do also very important duplex ultrasound, and the peak systolic velocity ratio more than 2, higher than 2, is going to correspond to more than 50% stenosis in the vessel. This is a good example about the things we need to keep in mind about our patients. What is a very common comorbidity that our patients with peripheral arterial disease have? Diabetes, right? And what kind of vascular insult do diabetics get the most? Small vessel disease. These patients have heavily calcified vessels. For this reason, our ABIs are not going to be reliable because they're going to be over 1.0 and not reliable at all. In this case, we can turn to toe pressures, PVRs. For example, here in this slide, our patient has mostly biphasic PVRs and a monophasic. Okay, so all of these are biphasic, and this one is a monophasic wave in the most distal left lower extremity. And here you have the toe pressures, right? Significant 0.4 and 0.47. So we have to keep in mind, like I said, the kind of patient we're dealing with. So next we're going to have the imaging, and we need to consider the advantages and disadvantages of every imaging modality according to our patient's needs. So for example, CTA, we have to be careful with contrast-induced nephropathy. We also have to keep in mind the blooming artifact from the calcified vessels. And for MRA, yes, there's no radiation, and the advantage is also that it's a 3D. But it depends. I think that we have to consider MRA when we have a good protocol, a good technician, when we have a center that has a high volume for MRAs, because technically I think it depends on how the protocol is done. So I know certain hospitals that don't have a lot of volume for peripheral arterial disease may rather do a CTA instead of an MRA because of the quality of the images. And angiogram, conventional angiogram, again, contrast may be an issue. You can use CO2 as contrast, and it's going to give you 2D images and not 3D. So it all depends on the patient. So for management options, once we have identified the disease and completed our workup, we need to assess the severity and location, which will help us choose the best approach from our pool of management options. The task classification, which stands for Transatlantic Inter-Society Consensus Document on Management of PAD, was published in January 2000 as a result of cooperation between 14 medical and surgical vascular, cardiovascular, vascular radiology, and cardiology societies in Europe and North America. An update of this was released in 2004, and an additional section of for infrainguinal disease was recently added, I believe in 2011 or 12. The lesions are classified from A through D, and these are the task recommendations. For task A and D lesions, endovascular therapy is a treatment of choice for type A lesions, and surgery is a treatment of choice for type D lesions. The task B and task C lesions, endovascular treatment is the preferred treatment for type B lesions, and surgery is the preferred treatment for good risk patients with type C lesions. The patient's comorbidities, full informed patient preference, and the local operator's long-term success rates must be considered when making treatment recommendations for type B and type C lesions. Keywords here in the first paragraph, treatment of choice, and in the second paragraph, preferred treatment. So these have all been challenged, right, in the past few years, where endovascular management has been done in multiple D lesions, type D lesions, because of the advancements in technique. So, like I said, and I'm going to keep saying throughout this talk, we just need to know the kind of patient we're working with. And having said this, there is a task classification for each level of disease. There's an aortoiliac task classification, and femoropopliteal and infrapopliteal. Because of the management recommendations are different in every level, and during this presentation, we're just going to focus on the management of femoropopliteal disease. This is the classification of the task and correlates angiographically. During this presentation, it is not necessary to memorize this. I think that the more cases you see and you're involved in as a trainee, either a medical student or a resident, the more you see, the more you will remember. So the idea is to recognize what A looks like, what D looks like, and you can always find this graph online and pull it up at some point. I mean, you don't need to memorize it, but at least kind of know the basics of it, and we'll see later when we discuss the cases, the more you see is better. I spent, I don't know, 2 years doing research in peripheral arterial disease, and I saw, I don't know, 50, 60 angiograms every day to classify this into task lesions. So the more you see, the more you'll learn, and it's everything that requires your memory. You can easily forget if you don't see it every day. So the Society for Cardiovascular Angiography and Interventions, the Society of Interventional Radiology, Society for Vascular Medicine, and the Society for Vascular Surgery got together and published the American College of Cardiology Foundation and American Heart Association Practice Guidelines recommendations for peripheral arterial disease. First released in 2005 with an update in 2011. And there are some recommendations here, class 1 recommendations for individuals with combined inflow and outflow disease. Inflow means aortoiliac, so keep that in mind. Outflow is all below. So for individuals with combined inflow and outflow disease with chronic limb ischemia, inflow lesions should be addressed first. For individuals with combined inflow and outflow disease and whom symptoms of critical limb ischemia or infection persists after inflow revascularization and outflow revascularization procedures should be performed. New recommendations from the 2011 update. For patients with limb-threatening lower extremity ischemia and an estimated life expectancy of 2 years or less in patients in whom an autogenous vein conduit is not available, balloon angioplasty is reasonable to perform when possible as the initial procedure to improve distal blood flow. And for patients with limb-threatening ischemia and an estimated life expectancy of more than 2 years, bypass surgery when possible and when an autogenous vein conduit is available is reasonable to perform as the initial treatment to improve distal blood flow. Again, all of this is being challenged by radiologists and advancements in technology, and especially the more clinical approach interventional radiologists are taking nowadays. And I think this is going to get even more challenged now by IR residency and our new wave of trained interventional radiologists being more focused on the clinical aspect of the diseases. Okay, so we're going to continue to the femoropopliteal interventions. So what can we do as interventional radiologists for this? The indication, we're going to talk about the indications and the contraindications. So for indications, lifestyle limiting moderate to severe claudications are ruled for 2 and 3. In patients who have failed medical management, critical limb ischemia, rest pain, non-healing ulcers, or gangrene, so 4, 5, 6, so basically everything. Pre or post bypass surgery to increase inflow or outflow, and salvage of failing bypass graft with significant flow limited stenosis of the anastomosis or outflow vessels. And the contraindications are not absolute. These are all relative contraindications. We can always correct the coagulopathy. We can always try to give the patient hydration, reduce the amount of contrast, or use CO2 contrast for severe renal insufficiency. Active phase of vasculitis, not preferable, but we can still do it. Mild claudication symptoms, that's debatable too, depends on the patient. SFA occlusion involving the popliteal and the tibioperoneal trunk. Hemodynamically significant common femoral arterial disease, that is also debatable. Traditionally, this CFA was not supposed to be stented, for example. I published a paper a few years ago on 70 cases where the CFA was stented and many times approached for other procedures in the legs below, and it was fine. The primary patency was about 80 or something %, and the primary assistant and secondary patency were 100%. So I think these are all not absolute contraindications. Still a little risky, I would say, to put a stent in the CFA. Absent runoff, hemodynamically significant inflow disease, which cannot be corrected by endovascular surgery, and severe aneurysmal disease at intended access site. So for pre-medication, per the clopidogrel versus aspirin in patients at risk of ischemic events Capri trial, there was a profound superiority in patients with peripheral arterial disease treated with clopidogrel over aspirin in the prevention of stroke, myocardial infarction, and vascular death. As a result of this trial, many advocate that clopidogrel Plavix be the antiplatelet medication of choice in the peripheral arterial disease population, given that the safety profile of this drug is at least as good as aspirin. All patients treated with drug-eluting balloons and drug-eluting stents will require dual antiplatelet therapy for a short period of time. However, per instructions of use, a minimum duration of dual antiplatelet therapy is 1 month and 2 months for Lutonix. Drug-eluting balloon, and so 1 month for Lutonix and 2 months for silver PTX. And we will discuss this later because these are the main papers we'll discuss today. If the patients have not been placed on any antiplatelet medication before the procedure, then there's a loading dose of 81 milligrams of aspirin or 300 milligrams of Plavix. And if all patients should have dual therapy, controversial, still continues to evolve this discussion, and the decision should be patient-specific, and the risks of vascular occlusion must be balanced with the risk of hemorrhage as well. So this is just about the procedure. We'll go over it really quickly for our medical students. We need to obtain initial arterial access, which can be contralateral, ipsilateral. The contralateral approach is the norm in most cases. An ipsilateral antegrade approach would be advantageous if below the knee interventions will be also performed. An ipsilateral retrograde approach may be preferred if there is significant common femoral arterial disease in the contralateral side. Another option, I know Dr. V has done this a lot, is pedal access. So it all depends on the patient. After that, we're going to perform an initial angiography, and including distal runoffs. And there's an example here of occluded SFA with normal 3-vessel runoff. It reconstitutes. Stenosis of more than 50% are considered hemodynamically significant in symptomatic patients and should be treated. These are just the recommendations for anticoagulation, and you can review them. I'm not going to talk about all this detail of the doses, but you can review that. And it's preferable to have an ACT more than 250 seconds. And if there's a stenosis, the anticoagulation will be given prior to crossing the lesion, and in chronic occlusions immediately after successful crossing of the lesion. Most of the time, 80 to 85% of the time, you can cross the lesion with a guide wire and, in a straight or an angle catheter. There's a Newton guide wire and a Benson guide wire, for those who have never seen it before. Then you have hydrophilic guide wires, the glide wire, the rogue runner. And if you cannot cross a lesion, you can always use crossing devices. This is the Vians. It's just a couple pictures for you to look at them and get acquaintance with them. You can always look them up. This is a true path crossing device. So if, let's say, you cannot cross a lesion at all, you can do a subintimal approach, where you're gonna go basically outside of the vessel in the intima and then re-enter the vessel safely. There's a loop technique, and you have to be experienced enough to do this. But like I said, 80 to 85% of the time you will be able to cross with just a wire and a catheter. You can have re-entry devices, the Outback, the Pioneer, Off-Road, and Interior. There are comparable patency rates. The advantages: increased technical success, ability to treat more difficult lesions such as test C or D. D is like the total occlusion over 20 centimeters. And decreased procedure time, contrast dose, and fluoroscopy time. Disadvantages: risk of vessel perforation, because we're going outside, we're going to the intima, and angioplasty-related vessel wear trauma. And this is just an example. A and B, baseline antegrade angiogram in a 60-year-old man with short distance claudication and occasional rest pain during the night, shows a long segment of test D, flush, total chronic occlusion of the SFA and proximal POP. The procedure was performed with CO2 because of impaired renal function. And in C and D, you can see subintimal recanalization with the Bolia loop, the loop wire technique, and targeted re-entry at the level of the P2 segment with the Outback catheter. So that's an option. And okay, we're going to do an angiogram to confirm intraluminal position. And for lesions less than 5 centimeters in length, balloon angioplasty is recommended. Longer or more complex lesions, more than 5 centimeters, a bare metal stent can be used. Balloon angioplasty is performed prior to the stent placement with a balloon 1 millimeter in diameter, less than the diameter of the target vessel, and the placement angioplasty is performed with a balloon of the same diameter of the target vessel. If a drug-eluting balloon is used, it can be of the same diameter of the target vessel for pre and post stenting dilatation. For very long lesions, the recommendation is to use covered stents. The lesions are more than 20 centimeters. And we also have another option, which is atherectomy. But if we're doing atherectomy, most of the time, depending on whoever's performing the procedure, an embolic protection device can be used. So this is the final result showing a widely patent femoral popliteal artery after a long 6-millimeter balloon angioplasty with the supera, which is basically a cover stent for long. You can see it there. It looks like a cover stent, like a regular stent for long lesions. Then we'll perform a final angiography with runoff, just to make sure that there's no distal embolization. Vasospasm, you can use nitro. Not a lot of people use it, but it's an option. And post-procedural management, manual compression, make sure that you have an ACT less than 180 seconds just to minimize the risk of bleeding. You can use closure devices. Some people like to use them, some people don't like to use them. Antiplatelet therapy, we already talked about that, and risk factor modification, the patients can be placed in statins. And then you're going to follow your patient with ABIs and duplex 1, 3, 6 into a month to check for patency and any complications. This one was a popliteal stent with a Tigris. This is from Gore, and I believe is used in Europe. This is a hybrid heparin bonded nitinol ring stent. And so you're going to see the next one is a picture of the stent with the knee bent. We never, we're trying not to put popliteal stents, but apparently this one is very dynamic and it avoids kinking and fractures. So something to keep in mind. This was from Europe, so we're not doing this in the United States yet. Okay, so for short and long-term outcomes, technical success in femoral popliteal stenosis is about 98 to 100%, and in occlusions is about 81 to 94%. Calcium is one of the primary determinants of immediate technical success and long-term vessel patency. Poor patency is associated with immediate elastic recoil of the treated segment, intimal dissection and late development of neointimal hyperplasia or progression of the atheromatous disease. Remember, this neointimal hyperplasia is the main factor for restenosis. There are different types of patency. I don't want to bore you with all the details with it. Basically, primary patency is what happens to the vessel you've worked on, if the vessel was never touched, or if it was if there was another intervention in the same vessel. Primary assisted, if it was another intervention in the same limb of the vessel you targeted the first time. And I'm sorry, that was secondary patency. Primary patency is if you did something else to the vessel. Okay. So these are clinical trials that we need to keep in mind. I'm going to mention it very fast. I think we'd all, as trainees, should read all of these. The Resilient, it was basically just comparing bare metal stents and conventional angioplasty. So for lesions less than 5 centimeters, angioplasty and bare metal stent was the same. So that's they recommend for lesions less than 5 centimeters to use angioplasty alone. The supera, like we mentioned it in that picture, is a new generation of bare metal stent with a flexible and strong interwound wire technology, and it's for more longer lesions. It has a good primary patency of almost 78.9%. We will talk about the Silver PTX a little bit more in depth later. The impact trial used the Admiral drug-eluting balloon versus conventional angioplasty, and the results were for 12 months. The primary patency was 89.8% versus 66.8% of the conventional angioplasty. So those were good results, and the mean lesion length was 8.9 centimeters in the drug-eluting balloon group. Target lesion revascularization was 2.4% versus 20.6% in the angioplasty group. We will talk about the 11.2, so I'm not going to go into a lot of detail because we will talk about the Lutonics. The Viper and the ViStar are basically bioactive surface stents that one has heparin and the other one has propane. So these are for way longer lesions, and the Viper was, the mean lesion length was 19 centimeters, and the ViStar was 19 and 17.3, and they've had good success. Primary patency in the Viper 73%, and 78 versus 54 in the ViStar study. So just keep in mind, when you review this talk again, keep in mind of these names and try to read this trial. It's very important for us to know. These are just for atherectomy. The Excite ISR and Definitive, they're both atherectomy devices. I believe the Excite ISR was the only one approved for in-stent stenosis, and we have the newer bioabsorbable stents, the Remedy and the Gaia, and we're still working on those, and we're still having more research on those. I don't think those are FDA approved yet, and we don't use them yet. But just keep in mind also that if you're using an atherectomy device, keep it in the back of your head if you need embolic protection. Right, these are my references. And I want to quickly ask if you have any questions about this part. We're going to move on to the journal primers, or the discussion of the papers. Do you guys have any other questions? I will take maybe like a couple minutes for questions now. Amber or Justin, do you guys have, did you see any questions?
No, I don't see any up right now.
All right, then we'll move to the, to just talk about the papers right now. Let's see.
Dr. Vatakencherry is also on now. If
oh, hi, Dr. B. We'll move to the journal primers right now, and then you'll be helping us with the discussion of the papers. So let's see.
Sounds good.
Thank you. So moving on, we will discuss 2 randomized clinical trials and 1 meta-analysis. We will do so in a journal primer fashion, which is basically a concise review that highlights key teaching points. Also want to point out that these journal primers will be available soon in the RFS website under the Vascular Disease Service Line tab for you to review them and kind of have them handy. You can download on your iPads, and if you're doing your IR rotation for the medical students, if you're doing residency or fellowship, I think it's a good way to review quickly all this very important landmark papers. So for our more junior trainees, medical students, I would like to introduce you to drug-eluting stents and drug-coated balloons, or drug-eluting balloons, which is the same. This term will be used interchangeably during this talk. Drug-coated balloons and drug-eluting stents have 2 main benefits. As the regular devices, they're able to provide the mechanical treatment to the obstructive atherosclerotic plaque. However, these also have the advantage to carry and deliver anti-proliferative drugs to the arterial wall. So that's the main difference with these drug-eluting balloons and stents compared to the regular ones. Okay, let's talk about the first clinical trial. Trial of paclitaxel-coated balloon for femoropopliteal artery disease, 12-month results from the 11.2 randomized trial. So what was the purpose of the study? It was to assess the safety and efficacy of the Lutonics paclitaxel-coated balloon versus standard PTA for the treatment of patients with femoropopliteal artery disease. The study was conducted from July 2011 to July 2012. 543 patients were prospectively enrolled at 54 sites in the United States and Europe. A total of 56 patients were enrolled in the roll-in phase, 11 patients with pre-dilation results indicating flow-limited dissection or clinically significant residual stenosis were excluded from randomization, and 476 patients were randomly assigned using a 2-to-1 randomization ratio to treatment with drug-coated balloon. These are the inclusion and exclusion criteria. So we have age more than 18, less than 85. They consider a Rutherford 2 to 4. So 5 and 6 was not included in the study. Stenosis of more than 70% with lesions length equal or less than 50 centimeters, or occlusion with lengths of equal or less than 10 centimeters involving the SFA and or the proximal popliteal artery. The target vessel diameter was between 4 and 6 and able to be treated with available device size matrix. For exclusion criteria, previous or planned surgical or interventional procedure within 2 weeks before or within 30 days after the index procedure. Any patients that had a history of MI, thrombolysis, or angina within 2 weeks of enrollment. Renal failure with a GFR equal or higher than 30 milliliters per minute, or a creatinine more than 2.5 within 30 days. Contrast allergies that could not be adequately managed with medication, and significant inflow disease. So the interventional procedures were performed as follows. Proctored roll-in angioplasty with a paclitaxel-coated balloon had to be performed before the first patient was enrolled in the randomized study so that the investigators and staff could be trained. So it's before any intervention happened. Dual antiplatelet therapy, just like we mentioned on the overview, with loading dose of aspirin and Plavix, and you can see that the doses over there. And if the Plavix was not available, they used Prasugrel. Post-procedure therapy with daily aspirin for indefinite time, and Plavix or Prasugrel at the same dose daily for at least a month. Patients were randomized after successful crossing and pre-dilatation with standard PTA 1 millimeter smaller than the reference vessel diameter. It's the standard, same as I explained before. Flow-limiting dissections or clinically significant residual stenosis more than 70% that was likely to require placement of a stent were excluded from randomization. Patients randomized to the experimental arm were treated with Lutonix paclitaxel-coated balloon at a dose of 3.5 plus minus 1.8 micrograms per millimeter square. Post-angioplasty was allowed to the discretion of the investigator, so not all patients got post-dilatation. So what were the outcomes of the study? The primary endpoints were primary patency at 12 months and a safety composite of included preoperative death, index limb amputation, index limb reintervention, and index limb-related death. So follow-up data was available on 96.6% and 95.9% of patients for the drug-coated balloon and angioplasty arms, respectively. Primary patency rates was significantly higher with drug-coated balloons than PTA at 12 months. So the primary patency for DCB was 73.5%, and for conventional angioplasty was 56.8%. So there's a difference there. Proportion of patients free from primary safety events was 83.9% with the DCB and 79% with standard PTA. And no significant differences between the two groups in regards of functional outcomes or in the rates of death, amputation, thrombosis, or reintervention was seen. Let's keep in mind, though, that the p-value for the primary patency analysis is 0.02, and for the safety composite, it was 0.005. So this has more validity, and I don't know if this is, I mean, it's clinically significant, but it's not less than 0.01. as Juana mentioned, to date, 2-year outcomes have not been published. They do have 24-month data. It is an ongoing study. They were not published, but they were reported, and I believe that was reported at the last Viva in Las Vegas. The primary patency rate was 58.6% versus 53%, with a p-value of 0.05, and freedom from TLR was 82% for the DCB versus 79% versus the regular balloon angioplasty, conventional balloon angioplasty. And this was not statistically significant. This is kind of questioning the durability of outcomes with low-dose DCB. So what we're going to find, I think, in all these studies is like, yes, the DCB and the drug-eluting stents work, but there's a lot of research that we need to do, more research. So I think there needs to be more papers and more investigation, and especially longer follow-ups for these studies, for these clinical trials. So bottom line, the paclitaxel-coated balloon resulted in higher primary patency rate at 12 months compared to the standard PTA among patients with symptomatic femoropopliteal disease, and drug-coated balloon was non-inferior to the standard balloon with respect to safety, so both were safe. So primary patency rate at 12 months was superior in patients treated with DCB when compared to patients who had undergone conventional PTA. The rates were 65.2% for the balloon, for the DCB, and 52.6% for the conventional angioplasty. Proportion of patients free from primary safety events was 83.9%. We already said that, and there were no significant differences between the groups in regards of death, amputation, thrombosis, or reintervention. Criticism for this study. So for appraisal of the study and trying to get the best of the study. The trial was not designed to have the power to detect a difference in rates of target lesion revascularization, functional endpoint, or quality of life, or a definitive assessment of this question will require a larger trial, and that's what we're talking about. I think this trial is good. It gives us an idea of where we're going and the direction we're going. The 24 months results that have not been published yet, I think they're not as encouraging as this ones, and I think we just need a larger trial and longer follow-up. This trial does not provide definitive guidance concerning the potential role of this paclitaxel-coated balloon in clinical practice either. And yeah, like I mentioned right now, long-term follow-up will be useful in determining whether the benefit of this intervention is sustained, increased, or attenuated over time. So we'll wait for those results, but this is a good paper to have in mind. So we'll move on. Dr. Lee, do you want to make a comment on the 11.2, or should I just go straight to the Zilver PTX and do it at the end?
I think you can just continue.
Okay.
Can you hear me?
Yes, yes, I can hear you. We'll just keep going. All right. So let's talk about our second trial, durable clinical effectiveness with paclitaxel-eluting stent in the femoropopliteal artery, and this was a very good trial with 5-year results of the Zilver PTX randomized trial. The purpose of the study was to compare the safety and effectiveness of the Zilver PTX, a polymer-free paclitaxel-coated nynol drug-eluting stent with standard conventional angioplasty and provisional bare metal stent placement in patients with femoropopliteal artery disease. So this is comparing drug-eluting stent versus conventional angioplasty with a bare metal stent. So they actually did, this is the schematics, the schematics of how they divided the patients. I'm going to go more in detail of how like the study was designed, but we have here basically the primary DS group, and there was the primary randomization went to the primary DS group and the PTA group, and then they decided to do a secondary randomization. So we'll talk about this right now. So the study was conducted from March 2005 through August 2008. 474 patients were prospectively enrolled at 55 sites in the U.S., Japan, and Germany. Patients were randomly assigned to treatment with drug-eluting stents with a sample of 236, or conventional angioplasty with a sample of 238. 120 patients with acute failure to conventional angioplasty were subsequently randomly assigned to provisional drug-eluting stent or provisional bare metal stent placement. And it was 61 for the drug-eluting stent and 59 for the bare metal stent. The study design included pre-specified comparisons of the primary DES group with the PTA group and the provisional DES group with the provisional BMS group through 5 years. The overall DES group, the drug-eluting stent group, including both primary and provisional, was also compared with the standard care group comprising patients with provisional BMS or bare metal stent placement plus patients with optimal angioplasty. Inclusion criteria was Rutherford 2 or more, and a resting ABI of less than 0.9. More than 50% diameter stenosis, reference vessel diameter between 4 to 9 millimeters, and a lesion length up to 14 centimeters, so it's longer than the drug-coated balloon study that we just talked about. At least one patent runoff vessel with less than 50% stenosis throughout its course. And exclusion criteria included untreated more than 50% stenosis of the inflow tract, lesion pre-treatment with other devices, and previous target vessel stenting. So, how is this? How is the intervention? How does the intervention go in this study? After baseline arteriography, eligible patients were randomly assigned to either conventional angioplasty or drug-eluting stent treatment, and we saw that they had 2 arms. So, the stent arm. Stents were implanted to fully cover the target lesion and were placed at least 1 centimeter below the SFA origin and above the medial femoral epicondyl. Predilation and postdilation were at the physician's discretion, with residual stenosis less than 30% required for procedural success. PTA was performed according to institutional standard practice. Acute conventional angioplasty failure was defined as equal or more than 30% residual stenosis, or a transtenotic pressure gradient of 5 or higher, and the protocol required 1 repeat 2 to 3 minute balloon inflation before conventional angioplasty was considered a failure. Patients experiencing acute failure with conventional angioplasty underwent secondary randomization to provisional bare metal stent or provisional drug-eluting stent placement. Conventional angioplasty treatments that did not accurately fail were considered optimal PTA, and these patients did not receive stents. The antiplatelet regimen was with Plavix starting at least 24 hours before the intervention, or a procedural loading dose of 300 milligrams orally. Continued clopidogrel therapy for at least 60 days after the procedure, and lifelong aspirin therapy, like we saw with the drug-coated balloon. In Japan, clopidogrel was not available, therefore ticlopidine was an acceptable substitute. And follow-up was a little bit more in detail, and especially because we're going 5 years into the future with this study. Follow-up included telephone contact at 1, 3, and 9 months, at 6 months, 1 year, and annually thereafter through 5 years. The in-clinic assessment included ABIs, Rutherford scores, walking impairment questionnaires, and duplex ultrasound evaluation of patency. High-resolution stent radiographs and planes were also obtained at 1, 3, and 5 years to assess stent integrity, so meaning looking for kinking or fractures. So what were the outcomes of this study? The clinical benefit defined as freedom from persistent or worsening symptoms, patency, and freedom from target lesion, revascularization for the overall DS group were superior to the standard care in non-randomized comparisons. So the clinical benefit, the patency, and the freedom from TLR were superior. And you see the red lines correlate to, or the red lines correspond to the drug-eluting stent group, and the dotted black lines correspond to the standard care group. So they had better rates, so 79.8% versus 59.3%. for clinical benefit. The patency was 66.4 versus 43.4, and freedom from TLR 83.1 versus 67.6%. And they were clinically or statistically significant. As you see, the p-value was less than 0.01. And this was the second randomization, right? The provisional DES compared with the provisional bare metal stent. So same, the clinical benefit, patency, and the freedom from TLR were improved over provisional BMS or bare metal stent. These are the rates, or the percentages: 81.8% versus 63.8, and 72.4 versus 53. 84.9 versus 71.6, but we have to keep in mind the p-value here is 0.02, 0.03, 0.06. So it's not statistically significant. So we have to keep that in mind. It demonstrates that there is a change and that there is a benefit, but this is stronger than this. Okay, bottom line, just a quick summary. Zilver PTX and drug-eluting stents provided sustained safety and clinical durability in comparison with standard endovascular treatment for the treatment of femoropopliteal artery disease, meaning conventional angioplasty with bare metal stents. I'm not going to repeat the major points because it's basically the same that I just mentioned with the graphs. The results represent higher than 40% relative risk reduction for restenosis and TLR throughout 5 years for the overall drug-eluting stent in comparison with standard care, and for provisional DS in comparison with provisional BMS. So that's very important, and that's good. It's an increase of 40% relative risk reduction. The criticism of this study: the lack of primary bare metal stent group for direct comparison with the primary DS group. However, the randomized comparison of provisional DS and provisional BMS placement allowed a direct assessment of the drug effect and showed significant benefits sustained through 5 years. Use of a conservative peak systolic velocity ratio in the study, less than 2, for evaluating patency by duplex ultrasound. I guess more recent studies have used a ratio a little bit different, less than 2.4 or 2.5. This was a little bit on the conservative side. So using a ratio less than 2.4 or 2.5 may result in higher patency rates than the ratio of less than 2 used in this study, and make a comparison more difficult. Okay, we have one last paper to discuss. So let's talk about our last study, and this is a meta-analysis of drug-eluting balloon angioplasty and drug-eluting stent placement for infrainguinal peripheral arterial disease. And this is a study, I mean, doing meta-analysis is hard, and especially with all this drug-eluting balloons and drug-eluting stent studies, because these RCTs are not all the same. They're confounding factors. It's difficult to compare them and analyze them. So I think this was a good study. It was published at GVIR last year, and I invite everybody to go to read it. And it's a good, I think it's a very good attempt on trying to analyze all this data. I think it's still difficult, and we still need more research, but this study was really good. So the purpose was to perform a meta-analysis of randomized controlled trials of drug-eluting balloons and drug-eluting stents for infrainguinal peripheral arterial disease. So they perform a literature search for drug-eluting balloon angioplasty and drug-eluting stent placement among databases over the last 60 years. This was the inclusion criteria. So the RCTs, which evaluated DB angioplasty or DES placement for femoropopliteal and or infrapopliteal disease. So this meta-analysis included FemPop and infrapop disease. Just we have to keep that in mind. Not all studies. So that's a little bit confounding, because drug-eluting balloons and drug-eluting stents have recently been applied to infrapopliteal disease. I think it's been longer the time that we've been using them for femoropopliteal disease, because the sizes, I think, were not available. They're smaller vessels, so but these kind of put them all together. And what they assessed, the main key points that they assessed was binary restenosis, so decrease in lumen diameter equal or more to 50%, target lesion revascularization, either repeat percutaneous or surgical revascularization, late lumen loss, and with a difference in minimum lumen diameter at procedure completion and follow-up, and amputation and mortality rates. The exclusion criteria, RCTs involving covered stents, the Biovent stent that I talked about earlier, were not included. Studies involving in-stent restenosis were not included either. And this is just a graph showing exactly all of the trials that they got. So for the drug-eluting balloon angioplasty, they obtained 8 trials, 763 patients total, 5 femoropopliteal, 2 infrapopliteal, 1 mixed. From the drug-eluting stent placement arm, they had 12 trials, 1,228 patients, 5 femoropopliteal, 7 infrapopliteal, and 0 mixed. So in total, they got 23 meta-analyses and 12 with significant effects. So what were the outcomes of the study? Data from 2 or more trials were combined for drug-eluting balloon angioplasty of femoropopliteal disease for late lumen loss, binary restenosis, and TLR, all which resulted in statistically significant benefit of drug-eluting balloon angioplasty versus PTA. Data were combined for amputation at 6 months and for mortality at 6 and 12 months and showed no statistically significant difference. So mortality and amputation, there was no statistically significant difference. Got to keep that in mind. Data from 2 or more trials were combined for drug-eluting balloon angioplasty of infrapopliteal disease for restenosis at 12 months and TLR at 12 months, both of which showed a statistically significant benefit of drug-eluting balloon angioplasty compared with conventional angioplasty. And this is for drug-eluting stents. So data from 2 or more trials were combined for drug-eluting stent placement for femoropopliteal disease in terms of late lumen loss at 6 months and restenosis 6 and 24 months, all of which showed a statistically significant benefit of drug-eluting stent placement compared with bare metal stent placement. Data from 2 or more trials were combined for drug-eluting stent placement for infrapopliteal disease. So we have here femoropopliteal and infrapopliteal disease. In terms of restenosis at 6 and 12 months and TLR 6 and 12 months as well, all of which showed a statistically significant benefit of drug-eluting stent placement compared with bare metal stent placement. So data were combined for mortality at 6 and 12 months and amputation at 12 months and showed no statistically significant difference. So again, the same as drug-eluting balloon, the drug-eluting stent, when the data was combined, and there was no statistically significant difference for mortality or amputation. But for all of the other endpoints, there was a big difference, and showing that drug-eluting balloons and drug-eluting stents are better. So bottom line, drug-eluting stents and drug-eluting balloons have superior outcomes in terms of late lumen loss, target lesion revascularization rates, and binary restenosis and compare to bare metal stents and as compared to bare metal stents and conventional angioplasty, respectively. Amputation rates and mortality are equivocal between drug-eluting stents and bare metal stents and drug-eluting balloon and regular or conventional angioplasty. So the major points were described already for FemPop, InfraPop, and there's a statistically significant benefit for drug-eluting balloons versus PTA and drug-eluting stents versus bare metal stents. Criticism: they did not stratify for conventional angioplasty versus bare metal stent placement prior to pooling. Variations between 2 statistically different control groups could identify relative variations between control and drug-eluting groups, the drug-eluting group, without real statistically difference existing between control and drug-eluting groups. Cost versus increased benefit ratio yet to be fully elucidated for DES and DVs, and additional concerns regarding length of follow-up, because the lengths of follow-up were different in all the studies. So, I keep mentioning, we need more research and longer follow-up. Underpowered study designs and heterogeneity in some of the meta-analysis. Bottom line, we need. It is difficult to compare all the studies, especially because of the population as well. Some patients are, depending on the Rutherford classification, depending on the task lesion, depending on what kind of patients they are, it's going to be a little bit more difficult to, if they have inflow disease, and I think there are multiple confounding factors, and it's going to be difficult to compare a meta-analysis or to actually analyze the whole data. But I think we're doing a good effort, and we should continue producing more high-quality research in interventional radiology. I would like to thank Joshua Owen, one of the RFS Vascular Disease Service Line members, for his contribution with this last journal primer. And I'm going to give Dr. V some minutes for discussion. And please, if you have any questions, this is the moment to ask. I think you guys, Justin or Amer, are going to moderate the questions. But I think that's it for now. And after Dr. V and all the discussion is done, we're going to move on to the clinical cases really quick before we finish. So Dr. V, thank you for being here today. I really appreciate it.
Yeah, it's my pleasure. Yeah, no, excellent overall overview of kind of peripheral arterial disease and the exciting new technologies, including drug-coated balloons and drug-eluting stents. I think the key points are, as you said, this is a highly prevalent disease, up to 20 to 30 patients that are elderly, 50 to 70 with diabetes and hypertension, or age over 70 will likely have some element of PAD and be underdiagnosed. And whether it be claudicant or critical limb ischemia, they're definitely under medically treated, meaning statins, ACE inhibitors, antiplatelet therapy, which will reduce their heart attack and stroke rates, but also our goal is limb preservation and improvement of limb function. So improvement of limb function, as you showcased in the Rutherford, is kind of those Rutherfords, twos and threes and ones in the moderate and severe claudicants, and limb loss really increases dramatically once you get into rest pain, where your foot hurts all the time, that you're gravity dependent, so you're sleeping in a chair or you're dangling your foot over the bed because you're so ischemic, or you have an ulcer that's not healing. And so those patients are high risk of limb loss if you don't revascularize them. And we started doing the interventions back in 1964 when Dauber opened up Laurel Shaw's SFA, so over 50 years ago. This kind of started, and now we're seeing very exciting technology that's able to improve patency and potentially transform, improve revascularization and make this potentially the gold standard. And it is important to understand where the stenosis is, whether it's inferior to iliac, femoropopliteal, tibial, and the severity of the disease based on task classification is long segment occlusion or short stenoses, very different. If it's a heavily calcified vessel, very different. Diabetics, very different. So knowing that as well. And there's going to be tremendous heterogeneity on the Rutherford, on the classifications in different trials. So it's really hard to compare one trial to another without a randomized trial. But these are two, kind of landmark trials showcasing the benefit of the drug. And that's been proven in the coronary literature. Now is showcasing in the peripheral literature that a drug, paclitaxel, or similar drugs have an impact and reduce restenosis, which has been the bane of interventional radiology or endovascular therapy of the vasculature, the restenosis and the scar tissue. So we can figure out ways to do that. It's great. And these are two level 1 randomized trials showcasing that there is a drug effect. So yeah, great job in presenting this very complex topic. Any questions in the audience?
Hey, Monica, thank you very much for the presentations. Obviously, you spent a lot of time on this presentation. I think it's a great learning experience for all of us. So David Petrov had asked a question, and I'll go ahead and address it here. He asked if there's been any updates on cost analysis on drug-eluting balloon versus non-drug-eluting balloon comparisons.
I'm going to defer that question to Dr. V. I did a cost analysis study, but I'm not very familiarized with cost analysis studies in regards to drug-eluting stents or drug-eluting balloons, honestly.
Yeah, and I think there is some ongoing discussion and evaluation, and especially in probably there's some data coming out from the tonics looking at 6-month, 9-month in the AV fistula world and restenosis, and it looks promising if you can reduce hospitalizations or graft thrombosis or require for a catheter, you could potentially have cost savings. So it's in the milieu right now, but I don't think there's good data yet.
Great, thanks. Thanks, Dr. V. So I had I guess just a curiosity question. So I'm not too familiar with drug-eluting balloons. Heard about them before. So when we're doing angioplasty, the balloon is in contact with the vessel for a relatively short amount of time. But the data clearly shows more of a long-term effect in the patency of the vessels. Do we have any understanding of the mechanism why how this works?
I'm sorry, can you the mechanism of what, the paclitaxel or the drug?
Yeah, is it the mechanism of paclitaxel? Because it seems like when we do angioplasty, it just we do it in that short amount of time, but then we're looking at a more long-term effect. Do you understand?
Right. So that's a good question. If you're doing a drug-coated balloon, the paclitaxel, how is it causing a reduction restenosis and into hyperplasia with a single deployment? Yeah, there's some antimitotic effect that's occurring that apparently has some duration of efficacy. Now, there is newer technology like the Lubia, which is looking at more longer-term elution. And so I think the Imperial trial is looking at 2 different types of elution profiles. So now what we're going to start seeing is not just drug, but drug versus drug, I think, and that's been in the coronary world where you look at one drug-coated stent versus another drug-coated stent. And so we're starting to see that even in the Femoropopliteal world, where they're going to look at a drug-eluting stent to the SFA and compare it to another drug-eluting stent to SFA. And so we're going to start to see, is there a difference in that? The original drug-eluting stent, which is the Sirocco, which is sirolimus-based stent, didn't bear out. So that was maybe 2004, so about 13 years ago when that virgin data came out. So it took a while for us to kind of get this sorted out. I think we're going to see various things where the way they hook up the molecule to the stent or to the balloon, and it's going to be all support. So there's a tremendous amount of variability in what's imperative, what's important in the delivery of the drug, and how it has impact, and how long you leave the balloon up. All these things are things we're learning. You have to get the balloon there in a rapid fashion. You have to leave it up for a few minutes in order for the drug to have adequate effect. You have to have adequate predilation so that the drug gets into the kind of periadventitial tissue. So there's a technical component as well to the delivery of the drug.
Okay, yeah, great. Thanks, Dr. V.
Also, I think they're comparing the doses of paclitaxel as well, because I think low dose, I think it's proven to be better. There are some drug-eluting balloons with higher dose. There's a study that I was reading about the other day. It's called the Illuminate study, and I think it's being done in Europe, but it's comparing a drug-coated balloon, kind of similar as a Lutonix, with a similar dose, but they're trying to make some changes. And like Dr. B said, I think it's just a matter of more research and trying to find the exact dose, exact time the balloon stop, or, there's going to be a bunch of comparisons, and we're still in the middle of trying to figure out this. So I think the results are good, and I think we're going in the right direction.
But the exciting thing is we're changing the gold standard in the endovascular world from plain old balloon angioplasty to drug-coated balloon or drug-eluting stent. And then it's going to be just slow evolutions of different types. So now the new gold standard is drug-eluting stent, and then we'll have to compare that to other newer technologies. So at least we're having a new gold standard, which I think is exciting.
Great. So does anyone have any more questions here? All right, so we got Bryson Bodell. He asked, regarding drug-eluting balloons, has there been discussion about using paclitaxel with cutting balloons?
The Lutonix has paclitaxel. It's a drug-eluting balloon.
Yeah, I don't know if that particularly has been studied. It's an interesting concept to see if you make kind of very precise cut, will that change the way the drug effect is on the periinterstitial tissue as opposed to plain old balloon angioplasty, where it's kind of a very unprecise dilation of the intima. I don't think that's been studied. What has been studied is intimal angioplasty. I mean, they've looked at drug-coated or cutting balloon versus plain old balloon angioplasty in kind of dialysis interventions, and that Dr. Vesely looked at that years ago. And the theory of the cutting balloons is that it reduces intimal hyperplasia by having very focused tear of the wall, whereas the plain old balloon angioplasty tends to be very kind of imprecise tear of the intimal wall. So that's been studied, and the cutting balloon didn't show any benefit for the plain old balloon angioplasty in reducing intimal hyperplasia, but the combination has not been studied as far as I'm aware.
And I don't think I haven't seen cutting balloons, but there are a lot of, not literature, but a lot of cases that I've been reviewing. There are a lot of people using atherectomy and drug-eluting balloons. So maybe that's something we should look at, and maybe some potential research.
Yeah, and I think when you look at atherectomy and balloon angioplasty alone, like what the data is at least showing initially is that potentially can reduce the risk of significant dissection by changing or remodeling the kind of the plaque, and so potentially reduce the dissection rate and need for stenting. And that's, I think, the DAR trial may have showcased that. So there is some suggestion that doing, some type of atherectomy and followed by low pressure angioplasty may reduce, full limb dissections or dissections requiring stents.
Right. Mm-hmm.
Cool. All right, so we have another question by John Doe. So quick question, caffeine has been reported to inhibit effects of paclitaxel on colorectal cancer, pancreatic lung adenocarcinoma. Is caffeine restriction indicated in patients with paclitaxel-coated devices?
No.
All right, there you have it. Any other questions? Okay, I think if not, for the interest of time, I think we can probably move on to the cases. What do you guys think?
I think that's a good idea. We're right on time. I think we should start the cases right now. Let me just switch.
Great. And if there's more questions in the meantime, go ahead and write them down. We'll address them after the case is completed.
Make sure this works. All right. Okay, so we're gonna try to apply these key concepts. I'm going to ask you to use your phones, tablets, laptops to review a few cases and like I said, apply these key concepts learned during the session. I'm very excited about this. We haven't done this before, so I see there are 25 attendees. Please use your mobile devices. We'll try to see how this works and maybe potentially use it again in any other webinars. I think this is a great idea to keep the audience engaged. So you don't need to download anything. You just participate by sending a text message or visiting the URL from any web browser. So moving on to case 1. This is the HPI 69-year-old female presenting with significant, significant bilateral lower extremity claudication, right more than left. Past medical history of hypercholesterolemia, and a duplex ultrasound showing more than 70% stenosis of both right and left SFA. So first question for our medical students, what is the Rutherford classification? And I'm going to give you a couple of, maybe like 2 minutes to answer. You can use the URL, or you can text that to that
Hey,
number.
Monica, so quick question. Do we have the URL links or the number to text you? Is that
No,
right?
you can just text from your phone. That's fine. Do you see it?
Oh, you mean just the chat function?
Are you able to see it? Are you able to see my screen? I'm sharing my screen.
I just see a blank screen right now. It's black.
Okay.
I'm not sure if anyone
No,
else is.
you can't see.
That's
Okay.
why. Okay.
Oh, here we go. Now I see your screen.
Can you see my screen now? Okay. Sorry about
Yep.
that. Where did it go? Sorry, guys. Okay.
Oh,
Can you
great.
see that now?
Yep. Great.
Okay. Sounds good. Let me just repeat that first one so everybody sees it. 69-year-old female, bilateral lower extremity claudication, hypercholesterolemia, 70% stenosis, so significant bilateral lower extremity claudication. So, okay, what is the Rutherford classification? That's a very simple question. I started with, I wanted this to be more directed towards the medical students, so you guys can pitch in. So you have 0, 1, 2, 3, 4, 5, 6. 1 to 3 is claudication, right? 4 is rest pain. 5 is gangrene. 6 is tissue loss.
Is it possible to go back one last time, just so everyone can see the question again?
Sure. You can see the question, right? But you want to see the case? Can you see the case now?
Yeah, right, perfect. Okay. And then what are the answers again?
I move this.
Or I guess the question and answers.
So what
what
is the Rutherford classification? Yes, everybody was listening, but no. Okay, awesome. So we said it was significant claudication, right? So 4 will be rest pain. So B is the right answer. Move on. And this was the pre-picture. So take a look at that. I'm going to give you a couple seconds. Let's say we are past the CFA. Just to say, quick hint. Take a look at that. Then the next question is, what is the task classification of that vessel or the lesions? Do you guys want to see the, I might just put it on again. What is the task classification? All right, I know this is difficult if you don't have that graph that I had at some point. So this is a task B because it has multiple less than 5 centimeters stenosis or occlusions, less than 15 centimeters. And A will be kind of like a milder type of lesion. I know it's difficult. I know you'll probably have to Google the graph, the schematics of it, of the task. Like I said, the more you see, the more you'll get familiarized with it. And what would be the best management option? And we have balloon angioplasty, and stent, drug-coated balloon angioplasty, or femoropopliteal bypass. So recapping, 69-year-old female, bilateral significant claudication. She's a Rutherford 3. She has a task B lesion. in one leg. Well, actually, she has bilateral legs, right? So what do you think? What would you choose? And I remember the recommendations I showed you guys at the very beginning. It says task D is definitely surgery. Task A was definitely endovascular. Task B and C were kind of debatable. Said the preferred for B was endovascular, preferred for C was surgery, but it was dependent on the patient and the activity of the patient. So what do you guys think? Okay, so we have 29% for balloon angioplasty, 57% for DCB angioplasty. Nobody chose the angioplasty plus stent. Interesting, because this is there are multiple lesions, less than 5 centimeters, but overall it's a total of less than 15 centimeters, so it's a pretty long segment of disease. I would think that my choice would be a conventional stent, conventional angioplasty with a stent, depending on how my results are with the balloon. But for the kind of disease, I'm going to show this again. For the kind of disease, I would do a balloon, and I'll put a stent as well. You can always use drug-eluting balloon, and if you needed a drug-eluting stent, so this was a tricky question. Dr. V, would you do the same balloon and a stent?
Yeah, it's a question of the hemodynamic severity, because I definitely see one that's truly significant. The others I'm not as certain. I may look at the PVR, I may do a translesional evaluation or IVUS to confirm. Mm-hmm. But based on that focal, pretty high-grade stenosis, that's, I think, probably the most significant one, likely to be causing claudication. I think PTA alone, but I probably, based on the more recent data, I'd go for DCB. But that's kind of, that's what I would right or wrong.
All right, so I'm going to tell you what people involved in the case did. ACCF diagnostic angiography showed a 98% stenosis of her right mid-SFA. The target lesion was successfully crossed with a run-through wire. After crossing the lesion, they did atherectomy with a diamond back 362 millimeter classic crown device, and at low and medium and high revolutions. And after that, they did a drug-coating balloon angioplasty with a 6x150 Lutonics, and their residual stenosis is showed in C, which was less than 20%. Any comments about that? So as Dr. V was saying, drug-coated balloons, we can use that. If that was his choice as well. They just helped here with atherectomy. We already mentioned when we were discussing the questions that atherectomy actually helps, and we've been seeing this a lot now. So moving on to the second case, 78-year-old female presents with rest pain and an ulcer in the second right toe. Diabetic, she has hypertension, chronic renal insufficiency, and she had angioplasty on the left side. She presents now with right side problems. So left side SFA, February 2015, she had a conventional angioplasty. So what is the ruler for classification for this patient? Remember, she had an ulcer in the toe, second toe. Yeah, somebody got the hint there. Okay, yeah, so this is a 5 because she has an ulcer. 4 is rest pain, and 5 is gangrene or ulcers. Right, so this is the lesion. I'm sorry, it's not big enough. They put 2 pictures together to get the long segment of SFA. So take a quick look at that. There's some tighter lesions than others. Very tight lesion in the mid SFA. There's another tight lesion, another tight lesion a little bit lower than that. Take a look at that, and I'm going to ask the same questions. What is the task classification? So remember what we said: A, B, C, D. First one was kind of B. It's pretty long, I would say. Total of there are multiple lesions. There are multiple less than 5 centimeter stenosis. There's very high stenosis as well, and they are at least more than 15 centimeters. All right, I'm going to show it to you again. Give you one more minute. All right, everybody going with C? C it is, yes, it is C. Less than 5 centimeters stenosis or occlusions making up for more than 50 centimeters of the total lesion. So yes. And so what is the best management option? You have conventional angioplasty, angioplasty and stent, DCB, bypass. Again, what would you guys do? This is a C lesion. So remember the recommendation said the preferred intervention would be surgery, but I think this is challenged. And I know it's all going to depend on the patient, but if you want to fix this vessel, I think it is fixable. I think you can do it endovascularly. It's a long lesion, though. I think I make it a little harder on you guys because he didn't add another option. But yeah, definitely balloon angioplasty. I don't think that's going to be enough. Balloon and stent, I think that would work. If I'm putting a stent in there in that lesion and it's really long, I think I would put maybe a cover stent. Drug-coated balloons, I think that's a very good option, and drug-eluting stents, I think it's a good option. So maybe I would do like DCB plus DS, trying to do it endovascularly. Bypass, I think, is also a consideration. So probably I would be between DCB plus DS versus bypass surgery, depending on the patient. If the patient has any contraindications for surgery, I will go for the endovascular approach. Yeah. Dr. V, what do you think about this case? Would you approach it the same way?
Yeah, I mean, I would probably go endo first approach. Most likely a mix of DCB plus or minus drug-eluting stent as needed. You know, I don't put a lot of coverage unless the alpha is really good. If you have 3-vessel alpha, then it's also a reasonable strategy. If she has autologous vein and the endovascular approach isn't working, that's also an option. But I would probably try to revasc this with the drug-coated balloon, possibly some orbital atherectomy, and possibly drug-eluting stent.
Okay, cool.
So DCB, DES, yeah.
Yeah, sorry, that's why I said I probably made it a little harder on everyone by not putting that option, sorry. And what they did here, the left femoral retrograde approach, crossover approach, guy wire passage of the SFA restenosis and filter positioning. They did atherectomy. They put a Urian protection system, and they did jet stream and balloon angioplasty with a DCB. So they did atherectomy with DCB. So yeah, I mean, there's several options. I think that this wasn't wrong at all. It's showing the results on the farther right side, and I think looks good. Atherectomy and DCB, but I think you can't go wrong with DCB and DS. I think that was fine. And last case, to wrap it up, 76-year-old male presents with right lower extremity breast pain. He has hypertension, diabetes, hypercholesterolemia, and the duplex ultrasound shows higher than 70% stenosis of the right SFA. So I know I talked really fast, but he had breast pain. Excellent. That was fast. So remember, 1, mild claudication, 2, moderate claudication, 3, severe claudication, 4, rest pain, 5 and 6 are going to be gangrene, tissue loss. So yeah, this is a 4, rest pain, and these are the lesions. This is the SFA. There's a chronic, there's a total occlusion there. Does not reconstitute from what we see. We don't see downstream down below, but this is the main picture of it. So what is the task classification of it? Yeah, it's deceiving. I see somebody saying D. Deceiving because I think the D is total occlusion over 20 centimeters. So believe it or not, this is a C. So 75%, yeah. You guys are sneaky. Okay. And last time, what would you do? I added a couple of different answers. So balloon angioplasty and stent, DCB and drug-eluting stent, atherectomy or bypass. What do you think? That's a pretty tight, I mean, it's completely occluded in the distal SFA. What do you guys think? Okay, interesting answers. 50% say bypass. I think I would have more faith. I think we can still attempt C. Of course, it depends on the patient. I mean, it's really hard, these cases, and I understand Dr. Lee, I'm putting him in a hard spot because, in a difficult spot, because it's hard to show from one picture just to the side. You have to know the whole history. You have to see the patient. It's difficult, but I would still think I'll attempt this endovascularly. Drug-coated balloon and stent, drug-eluting stent probably. I was going to ask Dr. V if you could do drug-coated balloon, atherectomy. Can you put a stent on top of that?
No, I mean, in a patient with CLI, I'm just trying to heal the wound. I don't, in general, control the rest pain. I don't need necessarily the durability of a claudican where I really need long-term pain. I just need enough time to get adequate flow to heal the wound. Because when you have a wound, you require about 6 times the oxygen nutrition that you would at rest. And so I just want to get robust flow. So oftentimes I'll just, DCB it and just get adequate flow and have good wound care, and hopefully that'll take care of it.
Okay.
You can atherectomy if you want orbital or whatever as an adjunct. There's not much data. And really, I mean, the data we have right now for critical limb ischemia, endo versus kind of open, is the basal trial. And so, and the best CLI trial is ongoing right now, where they're recruiting patients looking at endo versus bypass in patients who have autologous vein in the CLI population. So we'll have a little bit more data, but I think with transfetal access, as our approaches and catheters and wires improved so much and our wound healing has gotten better, that these task classifications are being challenged.
Right.
We can completely reconstruct the tibial circulation, even the pedal arch, and so we just got to get robust flow to the foot for an adequate time. Now, the newer technologies will also hopefully enable improved patency to maintain that architecture. So I think, again, this is a moving target, but, in general, we'll have an endo first approach most of the time for a lot of these.
Okay, well, thank you, Dr. V. I just wanted to say a couple things. We're going to wrap it up. I want to thank Dr. V. I want to thank everybody at the Vascular Disease Service Line for their support. Key points, I think, we as interventional radiologists or trainees going in interventional radiology need to keep in mind the clinical aspect of any type of, even interventional oncology. If we're doing a TACE, we need to really know all the clinical implications of the patient and take ownership of our patients. So we're seeing a change in our field where we're going to have beds, we're going to have inpatients, IR resident has critical care rotations, vascular surgery rotations, surgical oncology rotations. So let's move forward and try to be more proactive in that sense. That's always study and try to review the more updated clinical trials. I know it's difficult on top of all of our responsibilities to keep up with all the research, but read it and try to at least give it a thought. We as the vascular disease service line tries to put all of this in journal primers so you can just review them really quickly and to take advantage of that and be involved in research. I think interventional radiology in the eyes of medicine as a whole is a young field. We need more research, more high quality research. So be involved and try to produce high quality research in your own institutions. And just keep in mind, peripheral arterial disease is a tricky disease. It's a very complex subject. I think that's all I have for now. Dr. V, any final words?
Great job tackling a very complex topic and great overview on this thing with all the not only from the clinical presentation but the treatment options.
All right. If there's no other questions, let me change it back to my screen here. If anyone else has questions, go ahead and let us know while we're changing here. All right, if not, so again, thank you, Monica, for your presentation. They were excellent presentations. I think that all of us learned a lot out of this, out of the last hour and a half. You spent a great deal of time, obviously, on the presentation, so thank you very much. And I couldn't agree more with your comments. Again, and then thank you, Dr. Vatakencherry, for moderating the session. If you or your service line has topics to present for the future Journal Club sessions, please go ahead and either email me at the address you see here or Amr at his email address, and we'll add you to the presentation schedule. We've already had a couple requests from the ICU service line for presentations, so we'll try to get that organized soon. In the meantime, if you guys have any ideas, let us know. All right. Thank you, everyone, for attending. It was a great session, and hope to see you all next time.